Hello, everyone. Thanks for joining us for this evening's Study Hub session on Paediatric Emergencies. My name is Sandra, one of the Study Hub co-hosts, and I'm really pleased to introduce Dr. Abdullah Anis Khan, who is an ST1 in Paediatrics working at the Royal Surrey County Hospital. So I'll hand it over to Dr. Khan. Thank you and enjoy, everyone.
Hello, good evening, everyone. My name is Abdullah. Thank you, Sandra, for the lovely introduction. I've chosen these three topics for today. We're basically going to be dealing with common pediatric emergencies. So let's start with the first one. We're going to be talking about meningitis to begin with. Right, so we've all heard of meningitis. We know what it is. We know the common pathogens that cause meningitis. This session is mostly based on, mostly going to be focusing on our management of these situations and recognizing a potentially sick child who does present with these symptoms. So what is meningitis? It's basically an infection of the surface of the brain. You've got your meningeal layers, and they can sometimes be infected by certain organisms. It does not always have to be an infective cause. You can have meningitis, you can have something called aseptic meningitis, which is basically caused by certain autoimmune processes or malignancy as well. How does it work? So basically, the most common causes of meningitis are infective meningitis. And we've got, in peds, we like splitting up our age groups into different ranges. And we'll deal with that in a bit. So basically, the pathophysiology of meningitis is that you've got a source. You could have an open wound somewhere. You could have GBS colonization in situations where we're dealing with the newborn in the mum. So you can have a certain degree of bacteremia, which can cause a meningeal infection. It travels through the bloodstream, reaches the meningeal layers, and can cause, obviously, colonize that area and cause an infection. But the trouble with meningitis is the symptoms are actually as a result of the body's response to the pathogen. It's not always the direct insult caused by certain pathogens. In this situation, it's the release of certain inflammatory mediators. We've got our leukotrienes, we've got our cytokines, and all of these things which sort of get activated. There's a certain degree of endothelial damage, which will cause your symptoms like neck stiffness, fevers, and a rash, which is characteristic of meningitis. Moving on to disease progression, you can have patients who come in with cerebral edema, which is swelling of the brain, signs of raised intracranial pressure, and decreased cerebral blood flow, which can cause infarcts in the brain. It can also cause hydrocephalus because it will lead to fibrin deposition in different parts of the brain, and it can cause infarction as well. That can lead to a blockage in the flow of the CSF, which we'll talk about later, and that can give you hydrocephalus. So that's just basically a pathophysiology of how meningitis works and how these children will normally sort of present. If we're talking about the age groups that we commonly encounter, so in the neonatal age group, the most common thing, the most scary thing of them all is GBS. It's funny because in peds, GBS means Group B streptococcus. In adults, it can stand for some different things like most commonly the Guillain-Barré syndrome. But from the newborn period to the age of 3 months, the most common pathogen is Group B streptococcus, which is then replaced by, like I said, there's a degree of overlap between the ages of 1 month and 3 months. But then we have Neisseria meningitidis, which causes meningococcal meningitis. And then you've got strep pneumoniae, Haemophilus influenzae, and after the ages of 6, the most common culprits are Neisseria as well and strep pneumoniae. Viral meningitis is actually more common. It's about 2/3 of all meningitic patients who come with an infectious cause, but they're rarely more sort of critical. They tend to self-resolve. But the common pathogens are enteroviruses, adenoviruses, Epstein-Barr and mumps, which is now rare because of immunization and different immunization programs in the world. Right. Right. So how would a patient present with meningitis? It can be quite non-specific. I've actually put a couple of symptoms here in bold, so we can talk about them a bit more. Fever is, if I had to guess, 90% of our patients do present with a fever. But it's quite interesting to see the duration of the fever, the onset of the fever, and the age group in which you come with the fever. So, for example, if this was if a patient who's 2 months old would present with a fever, they would get full septic screen, which would involve a lumbar puncture to rule out meningitis. So, most common presentations: fever, headache. I haven't put that down here because that's part of the examination, but they do have a rash, which can be part of the history. And it's typically a non-blanching petechial or purpuric rash, which is quite sort of fast spreading, and it can sort of be accompanied with the headache, the photophobia. The most common complaint would be that the child is covering his or her eyes. They're using a blanket or something, and they don't want to be in a room full of light, so they prefer dark rooms and stuff. You have an irritable child. Now, this is also something that's quite relative, because everyone's got a different understanding of irritability. What we mean by irritability here is signs of cerebral irritation, which is basically a child who's just not himself or herself, and is there could be a behavioral change, there could be sort of aggression, anger, but that's sort of one of those symptoms that overlap with meningoencephalitis or meningitis and then encephalitis. But irritability is one of those signs that they do present with. Hypotonia, a floppy baby, could be a meningitic baby, could be a septic baby. So there's tons of things that are involved in the neonatal age group, but group B streptococcus can cause meningitis in the neonatal age group, and it can be deadly. They can also present with drowsiness. They can be off their food, off their drink, just not themselves, a bit sleepy all day, progressively getting worse. And then, mom or dad has a look and they find a rash on the tummy or the chest or the back, and then it starts spreading, and sort of that's how it generally proceeds. They can sometimes present with seizures. So it can be a brief history of fever, and then they can have seizures, and they can sometimes present in status epilepticus, which we'll talk about later. Or they can sometimes present after following a loss of consciousness, or they can present in a comatose state. That's obviously quite severe and luckily rare. We do tend to sort of catch these things a bit early. What will we be seeing on examinations? So the typical examination findings, there's obviously a rash, which is non-blanching. We've all heard of the glass test. You can see on the picture on the top right of the screen, that is a glass test, and you can see it's a non-blanching rash. So when you put a glass, it could be any glass, it doesn't have to be a specific type of glass. If you put any glass on it, it doesn't blanch, and that's scary, and that's dangerous. So the typical story is, because of all of these awareness campaigns, people are quite aware of a non-blanching rash and the glass test, and it's good because we tend to catch these things early because of all of this awareness. And they can have neck stiffness, but that's not always the case. In cases of infants under the age of 9 months, you can see a bulging fontanelle, which is, I'll be honest, it's quite hard to feel sometimes, because most of these babies will be crying, and crying can also cause for the fontanelle to bulge. But sometimes you can actually see a bulging fontanelle if you put them in a specific position and you palpate the anterior fontanelle. It can be bulging, which means which could be a sign of increased intracranial pressure. They can have a fistotonus, which is an arch sort of posture. Your back is basically completely extended, and it's quite stiff. You can have a positive Brudzinski and a Koenig sign. I'm sure we know about Brudzinski and Koenig sign. They're signs of meningeal irritation. One of them involves basically flexing the neck and flexing the knee, leg of the knee joint, and you'll have some back pain and neck pain with it. It's it has something to do with the irritation of the nerve underlying. There can be some focal neurology, because if I just go back for a second, we discussed that there can be cortical infarction or decreased cerebral blood flow. So that can actually cause damage to the matter of the brain. and it can cause some focal neurology. Or children can have focal seizures with a focal neurologic deficit. And as mentioned earlier, they can be confused or drowsy, or they could lose consciousness or present in a comatose state. So that's your reduced GCS. And if somebody is skilled enough to do ophthalmoscopy, then they can see papilledema as well. Right. So let's start with the picture on the left. So it's just basically all of those symptoms and signs we discussed earlier. So infants can present with a fever, and the most common complaint is usually a fever, off feeds, off food and drink, not weeing as much. So the number of wet nappies is not as much because they're not drinking enough and they're a bit dehydrated. They'll be irritable and they'll be miserable. And, the parents will say they're not themselves. They can have a fistotonus, which is the arching of the back. They can have a petechial or a purpuric non-blanching rash in extreme situations where they can present in shock. So you can have cold hands and feet, or sort of peripherally shut down cool peripheries, which is an emergency, which we'll see a little later on. Obviously, ignore the adult part because we're dealing with pediatric emergencies here, but it's generally the same. In children, you can have all of these symptoms, as you can see in this picture. There will be a degree of photophobia as well, and then we can obviously think about our differentials. It's always good to think about your differentials when you're dealing with an emergency. But again, we'll do a couple of scenarios again. We'll deal with that then. I hope you can see this. There's a bit at the top which I can't see as well. Hold on. Oops. Yeah. So what investigations would we consider when we are dealing with a patient who potentially has meningitis? It's always good to streamline your approach. So we obviously, because most of these kids will either present in the A&E because they're unwell enough, or they'll present to our ward in the assessment unit because the GP has seen them and is concerned about them seeing meningitis. So it's always good to start with your general investigation. So we'll do a full blood count, we'll do Usenes, we'll do a blood gas, a blood glucose level. Obviously, because there's a rash and it's non-blanching, do a coagulation screen, LFTs, take a blood culture because they've got fever, and we can do swabs. It could be a throat swab, it could be a nasopharyngeal swab or a nasopharyngeal aspirate, or it could be a wound swab as well if they have an open wound or the body which is oozing or something. So specific investigations would include CSF for culture and PCR, which is an LP, which is done by LP. You could take a sample for meningococcal PCR, which is actually gaining quite a lot of traction. It's a very good investigation. It helps us isolate these pathogens in the blood samples. You can take, again, so blood samples and CSF samples for PCR, or in rare cases where you're suspecting tuberculous meningitis, you can take gastric washings or bronchoalveolar lavages and stuff, but obviously that's not common practice for us. Imaging wise, we obviously need to see, so when a child will come with a fever, we need to see the source of the fever. You could do a chest x-ray, you could do a urine dip. In specific situations where we're concerned about meningococcal septicemia or meningitis and complicated meningitis, we would consider doing a CT scan of the brain or an MRI of the brain to check for signs of infarction, signs of hydrocephalus, or signs of cerebral edema. And if they've got seizures, and if after this they tend to have some kids would have complications, and that can cause seizures. So you can get an EEG as well. So this is just a comparative picture of, sorry, excuse me. It's a comparative picture of the results of CSF analysis, provided you actually get a good tap. So your normal opening pressures of the CSF are 5 to 20 centimeters of water. It's normally clear. There's no blood in it. And these are just the values we go with. Obviously, when you do a gram stain, there's nothing growing in that sample. The glucose level is 2.5 to 3.5, and you won't have a lot of white blood cells in it. And you can see in cases of bacterial meningitis, there will be an increase in pressure which we know because we would see signs of increased intracranial pressure. The appearance can be a bit cloudy, a bit turbid, just dirty looking yellow. You can have more protein in it. You will have less glucose in it because the bacteria is actually using the glucose up. And most of the times you will have some gram staining because in this situation, the most common pathogens would be either gram positive or gram negative. And yeah, so these are just the sort of criteria that we use to sort of differentiate the results between difference of meningitis cases. In viral meningitis, it's more or less fairly normal, but you will have an increased white cell count inside in the sample. And in cases of fungal or tuberculous samples, you will have a bit straw-colored CSF, and with all of these sort of differentials in it. You can sometimes have a lot of blood in it as well, because it depends on who's taking the sample. And sometimes you can have what we call a hemorrhagic tap, which is obviously not really helpful because it sort of skews the results a bit and it skews the interpretation a bit. But yeah, that's just for your learning, that this is how we sort of differentiate between different causes of meningitis based on the LP analysis. Right, so management. Now this is the important part, and let's see if we can work through a streamlined pathway for it. The first thing in every emergency, regardless of whether it's pediatric or adult, is your life-saving stuff. That's how I like to put it. It's your ABCDE assessment. Never forget that, because it's quite easy to forget, if I'm being honest, but it's something that will really define your practice as doctors if you can focus and streamline your approach to a potential life-threatening emergency. So we start with our ABCD approach. You look at the airway, breathing, circulation, disability, and then the environment for anything else. Sometimes, most of the time, these children can actually be quite sick. So it's always good to get IV access first, which can also be life-saving. They can be shocked. As I mentioned earlier, you can have a child who's presented off food and drink for 2-3 days, not himself or herself, not weeing as much. They'll be quite shut down. When you do their blood pressure, they can be quite hypertensive. So you'll have to give them fluid boluses according to the guidelines, which again, we can discuss a bit later. Now, this is really important, the fourth part. Do not delay antibiotics. Sometimes it's quite easy to forget. It's quite easy to get caught up in the excitement of everything, and people will be sort of quite keen on getting an LP or getting IV access and getting all these things in. But that can lead to a delay in antibiotics. So the goal here is to stop the course of the infection and the course of the inflammation. So we often start with third generation cephalosporins like cefotaxime or ceftriaxone. And outside the neonatal period, we can actually consider giving steroids like dexamethasone, which is quite good because it helps with cerebral edema. Ongoing management, obviously these children can be stabilized in the A&E. They'll be admitted as inpatients. And if they're stable, if they're hemodynamically stable, we can consider doing an LP because that will aid our diagnosis. That, number one, if they're stable. Number two, if there are no contraindications. The contraindications to LPs, just quickly, would be any sort of coagulopathies or any platelet problems if they're thrombocytopenic, if there's an open wound, if they've got like spina bifida or something, then obviously we will not do an LP because then there's no point. Focus on the neuro observations of these patients because they can quite quickly drop their GCS. So look at their pupils, look at the GCS, look at how they're acting, how they're behaving. If they're stable, we consider imaging. As I mentioned earlier, we do a CT scan of the head, the brain, MRI of the brain. You can do a chest X-ray to look for primary sources. It could be miliary tuberculosis presenting for the first time as meningitis. And you can consider giving antivirals. We do tend to cover these patients with acyclovir, which is quite sort of common. And then it's always good to think about escalation plans, especially in emergency situations, because you need to know where your limitations are. As I work in a DGH, and we tend to transfer all of our sick patients after initial stabilization to the Evelina Hospital in London. So sometimes these kids can require intensive care and sort of advanced airway support or circulatory support. And for that, we'll have to consider shipping them off to a tertiary center where they've got a peds ICU, and then we can get in touch with specific retrieval services that are available. Right. So this is basically a list of the common complications that we can see in patients who've had meningitis. So as I said earlier, viral meningitis is no more common, luckily, and it's luckily self-resolving. It's not that severe. Bacterial meningitis, however, it can be deadly. And the trouble is, if it doesn't kill you, it gives you a life of morbidity. It can cause, so let's just go sort of step by step. It can cause hearing loss because it can damage your cochlear hair cells in the inner ear. It can cause, because of the degree of inflammation, it causes local vasculitis. So you can have multiple cranial nerve palsies like facial nerve palsy or your sixth nerve palsy and stuff. It can also cause a stroke or localized cerebral infarction, which can cause seizures, or actually it can give you epilepsy for life because that specific part of your brain can be damaged. It can cause an infusion, which is quite common with the cases of Haemophilus influenzae, subdural effusion, which then can obviously behave as a space-occupying lesion. It can cause hydrocephalus, communicating or non-communicating. So a quick sort of update on that is basically hydrocephalus is increased amount of CSF in the brain, in the cranial cavity. Communicating means that it's the flow is going as it is. It's just sort of there's increased production of CSF. Non-communicating would mean if there's a fibrin deposit or like any obstruction to the normal flow through the ventricles into the aqueduct, then you can have hydrocephalus. The treatment is a ventriculoperitoneal shunt, which is obviously quite advanced, but that's one of the things we also have to deal with. You can have patients who come in who've got an existing VP shunt for another problem. They could have had a brain tumor or something, and that can also get infected sometimes. And that can often behave as a meningitis or meningoencephalitis. And sometimes in situations where the meningitis is partially treated, you can have cerebral abscesses, which again will behave as a space-occupying lesion because they can sort of increase in size and cause problems. So this often happens when somebody partially treats it with oral antibiotics, thinking it's a sore throat, and it leads to this, an abscess collecting in the brain. And abscesses obviously need to be drained, and that's a neurosurgical case then. Prognosis-wise, bacterial meningitis can actually have quite serious complications, as we've discussed. There's a 5 to 10% mortality, and there's over 10% of these children will have long-term morbidity, mostly neurological impairments. And as we discussed earlier, viral meningitis is usually self-resolving. Right, I hope I'm on time. We'll just go through a quick scenario. I've tried to sort of arrange this in a way where we can manage, where we can try and focus more on the management rather than what the diagnosis can be. So this is a 7-month-old boy who's presented with a 12-hour history of lethargy, spreading purpuric rash, and a fever. He's got no significant past medical history. He is unimmunized because his mom and dad didn't want him to be immunized. So you're seeing him in the A&E. He's listless, he's drowsy. Mom says he's been off his food and drink all day. There's a spreading rash, as you can see on the picture at the bottom left. This is quite an extensive rash. And so she's decided to come straight to A&E. So on examination, his obs look a bit like this. He's got a heart rate of 170. He's a bit tachycardic. He's got a blood pressure of 90 by 60, sorry. He's febrile. He's got a delayed cap refill time, which normal is 2 seconds or less than 2 seconds. This is 4 seconds. Sandra, am I on time? Oh.
Yep, we can hear you and you're on time.
Amazing, thanks. Right, so I want you guys to have a think of how you would manage this patient. I've listed out a couple of options. Have a think to yourself how you would want to prioritize your approach in this situation. I've got a couple of options. We've got IV access plus fluid resus, your ABCDE approach. You've got an LP, a COVID swab, given the times we're living in, IV antibiotics, and imaging. So let's give ourselves 10 seconds. Think about how you would want to prioritize your approach. Right. So this is the same boy who, unfortunately, I've taken these pictures from an old book I read in med school. It's an excellent book. It's called Illustrated Pediatrics by Tom Lissaw. So you would prioritize your approach by following the ABCDE approach. Always focus on the airway, because if the airway is not right, you can't move on to the next step. You cannot stabilize this patient. Focus on your airway, your breathing, your circulation. Let's go back to the scenario. So you know the stats are 96. There's no mention of any airway problems like stridor or anything. So you know your A is fine. Move on to the breathing. You will have a listen of the chest, see whether you've got equal air entry, if the chest is rising and falling equally with each breath, and then you can move on to C. So clearly the problem here is C, because we know this child is shut down peripherally, he's hypertensive, he's tachycardic, you know there's a response going on in the body, and he's got a delayed cap refill. So that is C is going to be our problem, basically, that we need to solve. So gain IV access quickly, double lines in both arms, as wide a bore as possible. Start aggressive fluid resuscitation with fluid boluses. We follow the advanced pediatric life support guidelines, the APLS guidelines, which we don't have to go through right now. And obviously, do not delay IV antibiotics. That is key here, because so this is the same child on the right side. He's fine after all of this. So the reason I share this picture is because you can see how disseminated the rash is. If it's such a bad rash, it's actually called purpura fulminans. It's just widespread, non-blanching purpuric rash, and they can actually quite often end up in PICU. And they can be ventilated and sort of end up on cardiac support for a long time. Right. So that is the end of our first topic. We'll just quickly go through the high yield points. The one thing I would want everybody to take away from this session is do not delay antibiotics, especially for investigations like an LP. It happens more frequently than we would want to admit. Always think about sepsis in situations where you have a child who's sort of febrile, who's got a rash. Think about your ABCDE approach and make that a priority when it comes to managing these patients. And always focus on the history, because a good history can save you a lot of embarrassment later. I've also taken an excerpt from the same book I was mentioning earlier. Meningococcal septicemia can kill children in hours, and optimal outcome requires immediate recognition. So that's your history, your examination, and the presentation of the patient, proper resuscitation, and antibiotics. So do not forget your antibiotics. Do not forget your ABCD approach, because that can eventually save a life.